So welcome everyone. So today we're going to talk about two cases of babies with heart problems, causing them to come into A&E in a collapsed state. I'm just going to talk about them because I found them very interesting cases when I saw them and had some key learning points from them I'd like to share with you. So I'm going to talk through them as if it's a case that's happening, so to try and help you think what you would do in that situation. And I'd like to hear if you write your thoughts in the chat box while we go along, so can hear your thoughts. So you're in A&E, 2 in the morning. A call comes through that's a 5-day-old floppy baby who's coming in. You get a handover from the paramedics. It's a 5-day-old baby. There's been reduced feeding for the past 2 days, and they've been breathing faster for the past day, and they're floppy and pale. Is there anything else you'd want to hear about the history at the moment from the mum? Yeah, no temperatures. Okay, so baby born at term, normal delivery, no risk factors for infection. There was a history of, during the newborn check, there were concerns regarding reduced femoral pulses. And then a senior doctor reviewed, thought they were fine. There's also a murmur that was heard. So they arranged for, they weren't too concerned, so they discharged and they arranged for a cardiac follow-up in the future. So you see the baby, their airway's patent, you can hear them moaning. They're tachypneic, saturation is okay, and they've got mild subcostal recession. And on listening to them here, you hear good air entry bilaterally. They're tachycardic, you can't measure the blood pressure. They're grey and mottled, and they've got prolonged capillary refill. And you hear a systolic murmur at the left upper sternal edge. You think it's about 3 out of 6 grade-wise, and you can't feel the femoral pulses. They are just about responsive to pain. Pupils are equal and reactive, and they're afebrile. Their tummy is soft, but you can feel the liver at 3 centimetres. So anything else you want to know from your examination? No family history of cardiac problems. Fall in blood pressure, very good question. So the blood pressure is unrecordable, is on the leg. So you ask the nurse to do it on the arm, and that blood pressure is 60/40. And then you measure the saturation. So that saturation was measured on the right arm. And then you measure a saturation on the leg, and that's 70. Good. All right, all very good points. So then you do a gas, and you see that they're acidotic, and their lactate's quite high at 8. So what are your thoughts now for management? What would you like to do? ABC, good. Yeah, Prostin, good. So we're thinking congenital heart disease here. Possibly inotropes. Bolus, good, 10 ml per kilo. And oxygen. Good. These are all good points. So your differentials at this stage, so you're all going for the congenital heart disease here, which is very good. It does very much sound like that. As with all collapsed babies, you have to think sepsis, as that's one. You'd want to do broad spectrum neonatal antibiotics, so cefotaxime, amoxicillin. You might want to start acyclovir. And then yeah, and then you're thinking your congenital heart disease, which you guys are mentioning, and also less common, but still need to be at the back of your brain for neonatal collapse, metabolic and non-accidental injury. So I think you've actually said most of the management points. So just bring them up. So you've got a collapsed, reduced consciousness in the baby. So you initially start high flow oxygen. If you had a nice neonatal resuscitator, you'd have your Tom thumb, probably give a bit of pressure with that as well. Once you're, and then you get your IV access. This baby needs IV access quickly, so you could try your peripheral cannulas first. Maximum you want to do 2, maximum sort of 30 seconds each, but they are going to be difficult to get access on. So you have to be thinking about interosseous, maybe UVC if it's possible. And then when you've got your IV access, you send all your bloods, including for signs of infection. And then you give your IV bolus. As someone mentioned, you give 10 ml per kilo. You think this is likely a newborn with a cardiac condition. So you're always very careful with your fluid boluses. You don't want to give too much. You might already be at the end of your Starling curve, and actually giving fluid might make them worse. So you give your 10 ml per kilo normal saline bolus and see how they respond. If the heart rate's coming down, if the blood pressure's improving, then you might consider giving more. So then you'd also start IV maintenance fluids. You're concerned it's cardiac condition, so you might want to give below sort of 2,000 maintenance. Insert NGT, always very important before you're going to consider intubation, because this baby is poor conscious level, won't be able to maintain their airway, so you want to intubate. And you need to make sure you've given that fluid bolus beforehand, because you want to try and maintain a much cardio stability as possible before you give them the drugs which might reduce their cardiac output and make them worse. You start antibiotics, because you always want to cover for sepsis, and as you mentioned, you start Prostin. A bit later we'll talk about how much Prostin you're going to start here. You're concerned it's a cardiac condition, so you're going to be ringing the cardiology team for advice and to make sure they're happy to take the child, and you'll be ringing the retrieval team, who will be giving you advice about how to manage this patient, and then hopefully take them over to the cardiac centre. Has anyone got any thoughts what this condition could be? Coarctation, yep, it's a good answer. Yep, everyone's saying coarctation. So some kind of, duct-dependent systemic lesion, so coarctation, or in this case, is an interrupted aortic arch. So this particular baby had a type B interrupted aortic arch. That's the most common, it's 50%. So also, when you're initially looking at the baby, something to look for when you're concerned about congenital heart diseases, a lot of them associated with genetic conditions, and an interrupted aortic arch is particularly associated with this condition that this drawing is supposed to show. I don't know if there's any thoughts. Not Williams. It's not a very specific drawing. To George. So low set, it's supposed to show low set is bulbous nose, narrow epicanthic folds, short filter and micronathia, and then they have cleft lip and palate as well. So this is a very rare condition, 1 in 200,000. It's generally a VSD because of the arrangement within the heart. And then they go to the cardiac centre for corrective surgery, where you basically attach the 2 parts of the aorta together, and you might need a homograft or a patch to be able to do this. So this is a duct-dependent systemic lesion. So with these, you have an obstruction somewhere on the left side of the heart. So basically, you can't get blood flow to the rest of the body systemically. So you're dependent on that duct and the blood flow coming to the right side of the heart to go through the duct and get to the body. With a duct-dependent pulmonary circulation, it's the opposite. So you've got an obstruction somewhere on the right side of the heart. Duct for the blood to go through to the lungs from there. And then a duct-dependent mixing lesion is when you have two different circulation pathways, and the duct allows communication between these two, i.e. in transposition of the great artery. So Prostin, how much? This was my key learning point from help looking after that baby. I found it's a useful guideline by the PECSIC group, who are the paediatricians, secretaries in cardiology. So normally when you have a baby with an antenatal diagnosis of a duct-dependent lesion, you start them on, 5 of Prostin, and they're stable on that. But with this kind of baby who came in collapsed, acidotic, you need to reopen that duct. That duct was initially open when they were born, and then it's closed down. So you start. You can start at a much higher dose of 50. So the problem with that, having such a high dose, is the side effect of apneas, and you can get apneas generally above 15 of Prostin. But as with this baby, they're collapsed unwell, so they'll generally be intubated, when they come in. And by the time you've got that Prostin ready, they're already intubated. So you can start, you can start at a higher dose. And then if that's still not working, you can go up to 100 if necessary. I mean, obviously all this you'll be discussing with the cardiology team at the time. Does that all make sense? You got any questions about that at the moment? No? Okay, good. So moving on to the next case. So you're in A&E, it's a much more sensible time of the day, it's 2 p.m. And you're told there's a 6-month coming in with problems with breathing. So the handover from the paramedics is that he's been struggling with feeds over the past few weeks and has increased work of breathing, especially after feeding. And he's been particularly lethargic the last few days. So when you have a look at him, he's grunting, he's tachypneic, saturations are okay, and you listen to his lungs, there's air entry equally bilaterally, but there are crackles posteriorly. He has, he's tachycardic, heart rate of 180, blood pressure 60 on 35, and you listen to his heart sounds, and there's this extra heart sound. So you've got a gallop rhythm, and you can hear a 3 out of 6 systolic murmur in the apical region. He's lethargic, he's crying intermittently. He hasn't got any fevers, and his abdomen is soft and tender, and his liver is very big. You do a gas, and numbers are looking okay. And you do a chest x-ray, and you see this. Good, so yeah, so people are saying heart failure. One of the causes of that is myocarditis. Any other differentials at this stage? Yeah, congenital heart disease, good. Our kappa, metabolic condition. Yeah. Good, so very good list of differentials here. I'd always generally include sepsis as well when a child comes in like this. So what would you like to do for your management? Yep, ABC. Get some IV access, call cardiology, arrange an echo, cautious fluids. Anti-failure. I'm guessing, yep, diuretics. Drugs. Oh, anti-failure drugs. Okay, sorry. Good. Good. Yep, all excellent suggestions. So you're going to give CPAP. So you want to give PEEP because when you've got cardiac failure, it helps push the fluid out the alveoli back to where it should be, and it also reduces your preload by increasing your intrathoracic pressure, which allows the blood flow to come back to the heart, so reducing your preload. You're going to get your IV access, send bloods also for an infection screen, and you start your diuretics. So what diuretics do we normally use in this situation? Frusemide, good. So you give 1 mg per kilo stat dose of frusemide. Give that intravenously. And then if this is helping the patient, you carry on with frusemide and also add in spironolactone at a similar dose, and that helps to control the potassium. IV antibiotics, because this could be sepsis. Bring your cardiology team, and then your retrieval team. So someone suggests, oh, maybe let's do an ECG as well. Anyone got any thoughts about the ECG? Oh, sorry, how do you manage fluids? So you generally give sort of 2/3 IV maintenance, and you'd want to stop your feeds initially because increasing the volume within the stomach can affect the breathing within the lungs. SVT, okay. So SVT, I can see good P waves, all in the going correctly up or down. So I wouldn't say it's SVT. Yeah, some ST elevation. Yeah, you can see that in V4, V5, and V6. It was one of the differentials someone actually gave earlier was the right answer. You can see it on the ECG. Okay, so there's quite impressive Q waves in the anterior lateral leads, and also 1 and AVL. Anyone know what that diagnosis might what that might suggest to be the diagnosis? Yay, Al Kappa, well done. So yeah, bad joke. So Al Kappa, i.e. anomalous left coronary artery rising from the pulmonary artery, very rare, 1 in 300,000. And it generally presents between 2 and 24 months of life. So this is just a diagram to show it. So you can see the left main coronary artery coming off the pulmonary artery there. So it's all in blue. So they present after 2 months of life. This relates to when the pulmonary pressures drop. So initially when you're born, your pulmonary pressures are quite high, and then by 6 weeks of life, they've dropped to adult level. Now, when the pressure within the pulmonary artery drops, the blood doesn't go into the coronary artery anymore, and actually it can go back the other way. So the heart ends up having ischemia, and then you go into heart failure. So you can get collaterals growing, so you can just see there it says collateral, and this can help give blood supply to the left coronary artery. And in fact, I once saw a 9-year-old who had such good collaterals, well, that she didn't present till she was 9. And then this is just showing why you get the Q waves in this position. So if you look at the left coronary artery here in red, it supplies the anterior and left side of the heart, and that's reflected on the ECG. That's a shame. I had a picture from an echo, but it hasn't come up. Sorry about that. Just showing the coronary artery coming off the pulmonary artery. So I just really like this. I found this case interesting and a good learning point, because we don't always think about doing ECGs with these children, because it can help point to the diagnosis. Not that it would really change your management plan at the DGH when you're doing the initial management for them. So cardiac failure in infancy. So cardiac failure is when it's defined as your heart not sufficiently providing blood to the rest of the body to allow metabolism to happen normally. And this may be because you've got an abnormal myocardium, or you've got a normal myocardium and there's something else that's stopping the flood from flowing appropriately. So with a normal myocardium, so you can have too much fluid going around. So with the case, very rarely you can get a vein of Galen in newborn babies. So they'll present with signs of cardiac failure, and you can't find the cause. You do an echo, there's no obvious reason. And then someone pops a stethoscope on top of the head, and they can hear a bruit, and that can help lead to the diagnosis. Then sort of beyond 6 weeks of life, you can present with left to right shunts. And you present at that age once again because that's when the pulmonary artery pressures drop. So it allows for more and more blood to go from the heart to the lungs, back to the heart, lungs, etc. So you end up with too much blood going around, around, around. And then you could also, like with our case with the interrupted aortic arch, if you get an obstruction somewhere, it can end up with too much back pressure and therefore causing your heart to fail as well. And then our second case, we spoke about a case of abnormal myocardium. So coronary abnormalities, we discussed the Al-Kappa. You can also get weird variants like an imperforate coronary artery. And these cause ischemia and the heart myocardium not being able to work effectively. Another cause that people suggested as a differential is myocarditis, and this can present at any age. And then cardiomyopathy with your different metabolic conditions. And also arrhythmias. So also a tachyarrhythmia and a bradyarrhythmia can result here. So if you have an SVT for a long period of time, they can go into cardiac failure, and also with a congenital heart block could cause cardiac failure as well. So we went through the management earlier with the previous case, but so diuretics are very useful. They reduce your preload, and then the CPAP, giving the PEEP, helps push the fluids into the lungs and also reduces your preload. Inotropes, so it's not something you'd really use in the DGH. Perhaps the retrieval team at the cardiac centre would use that, but milrinone reduces your afterload by causing vasodilatation, so it allows the heart to pump more easily. And then at the cardiac centre, they'd correct the underlying condition. So with the two conditions we spoke about, both with surgery. Any questions? Thank you. So you, I mean, you can measure troponin as well. It will be raised in these patients. I don't know if it would guide your management very much initially. Okay. Well, thank you very much. I hope the rest of your day is okay. If you wouldn't mind filling in the feedback, it would be very helpful. Thank you.